Do you find yourself leaning closer to the page and then realizing the page was never the problem? Do you drive at dusk and notice that the oncoming headlights seem to bleed into something wider, something blurrier than they used to? Do you sit in a room you have sat in 1,000 times and feel, just slightly, that the edges of things have lost their sharpness, like the world has been turned down 1 degree from what it was? Not dark, not painful, just softer, just less crisp than you know it should be. If any of that sounds familiar, I need you to stop what you are doing right now and watch this entire video. Because what I am about to share with you is not a conversation about glasses prescriptions or dry eye drops or the ordinary diminishment that optometrists chalk up to age. This is clinical information. This is information about the underlying mechanism that most people experiencing exactly what you are experiencing have never been told. And in many cases, it is the difference between intervening early and watching a serious condition accelerate until it becomes something much harder to address. Most people who go to their doctor describing this kind of gradual visual blurring hear a version of the same response. Your prescription has changed. It happens as we get older. Let's update your lenses and come back in a year. And they leave with new glasses that help for a while, sometimes don't help much at all, and the underlying process continues. The blurring continues. The fatigue behind the eyes continues. The moments of sudden haziness when you turn your head too quickly continue. And because nothing dramatic has happened, no sudden blindness, no acute event, they assume they are managing it. They are not managing it. They are not addressing it at all. I am here to tell you that what you are describing is not primarily an eye problem. I know that is not what you expected to hear. I know it runs against everything that has been communicated to you. But the mechanism I am going to walk you through today will explain, in precise anatomical terms, why so many people treat their eyes for years without ever resolving the visual decline they are experiencing. And once you understand that mechanism, the path forward becomes clear in a way it has never been before. My name is Dr. Reed Cross. I have been in clinical practice for more than 23 years, working at the intersection of neurology, vascular medicine, and the musculoskeletal system. And in that time, I have seen one pattern repeat itself with enough consistency that it has become one of the central organizing principles of how I approach patients presenting with visual complaints in their 50s, 60s, and 70s. They come to me talking about their eyes. They leave understanding that what they thought was an eye problem is actually a brain circulation problem. That distinction is not semantic. That distinction changes everything. Before I explain the mechanism, I want to give you a picture. Imagine you are standing in front of 3 different people, all 3 of them struggling with blurred or unreliable vision. The first is a 71-year-old woman in Phoenix who has been updating her glasses prescription every 18 months for the past 6 years and still cannot read a restaurant menu comfortably under dim light. The second is a man in his late 40s, sitting in a car dealership waiting room, dizzy and nauseated, because 90 minutes ago he got a cortisone injection in his neck and something went wrong with the delivery. The third is a 64-year-old retired professor in Vermont who woke up one morning and noticed that traffic signs seemed just slightly harder to read than they had the previous week. All 3 of them have visual symptoms. All 3 of them would describe their experience in similar terms. But if you put any experienced clinician in that room, they would give you 3 different explanations, 3 different mechanisms, and 3 completely different intervention approaches. Because the cause in each case is entirely different. That distinction is not a minor technicality. That distinction is the entire point. Here is the mistake I see repeated over and over, not just by patients, but sometimes by practitioners who should know better. Someone's vision starts to soften. Things get slightly harder to track. Night driving becomes subtly more effortful. Their first instinct, completely understandable, is to attribute this to the eye itself. the lens, the retina, the fluid pressure. So they go to the ophthalmologist. They update the prescription. They start using lubricating drops. Maybe they get tested for early cataracts, early glaucoma, early macular issues. Maybe nothing significant shows up. Maybe something minor does. And months pass, sometimes years, and the visual picture continues its quiet deterioration. Because they have been treating the hardware and never once looked at the power supply. Your eyes are not running this show. Your eyes are extraordinary instruments, the product of hundreds of millions of years of biological refinement. But they are receivers. And a receiver, no matter how precisely engineered, cannot perform its function if it is not receiving a full and consistent signal. The signal in this case is blood. Oxygenated, nutrient-rich blood delivered at volume and pressure sufficient to sustain the most metabolically active tissue per unit area in the entire human body. That tissue is your retina, and the engine coordinating and processing everything that retina captures is the visual cortex of your brain, sitting in the occipital lobe at the very back of your skull. What feeds that cortex? What feeds the processing centers responsible for translating raw visual data into the sharp, coherent, detailed world you are meant to experience is the posterior cerebral circulation. And the most anatomically vulnerable portion of that circulation runs directly through your cervical spine. I want to pause here and share a number with you because it reframes everything. Your brain is approximately 2% of your total body mass. 2%. And yet, it consumes roughly 20% of all the oxygen you breathe and 20% of the glucose circulating in your blood. The brain is not just the most important organ in your body. It is the most expensive to operate. It is extraordinarily sensitive to even modest, sustained reductions in the blood flow that supplies it. And of all the regions of the brain, the posterior region, the occipital lobe, the visual cortex, the structures responsible for processing and interpreting what your eyes send it, is supplied almost entirely by one vascular system, a system that is architecturally unlike any other major circulatory pathway in the human body. Let me tell you about the anatomy, because this is where everything comes into focus, and I want you to understand it clearly. Running up either side of your cervical spine are two arteries called the vertebral arteries. What makes these arteries unlike virtually any other major artery in your body is that they do not simply run alongside the spine. They run through it. Each cervical vertebra has a small opening on either side called the foramen transversarium, and the vertebral arteries thread through these openings, one vertebra at a time, ascending through your neck like a cable routed through a series of rings. When they reach the top of the cervical spine, they wrap around the atlas, the first vertebra, the one your skull rests on, and they enter the base of the skull. Once inside, the two vertebral arteries merge into a single, larger vessel, called the basilar artery. The basilar artery then divides into the posterior cerebral arteries, which are the primary blood supply for the occipital lobe, the visual cortex, and the entire posterior region of the brain responsible for processing sight. This entire vascular system is called the vertebro-basilar circulation. It is the most structurally vulnerable major circulation in the human body, because it is literally threaded through bone. It is not protected by soft tissue. It is routed through a series of bony channels that are directly affected by the alignment, the mobility, and the chronic muscular tension of your cervical spine. If those vertebrae are even slightly misaligned, if the surrounding musculature is in chronic spasm from years of screen time and forward head posture, and old injuries that were never properly resolved, those arteries get compressed. They get kinked. Not catastrophically, not enough to cause an acute event in most cases, but enough to reduce the internal diameter of the vessels persistently, enough to reduce the volume of blood reaching the posterior brain by a meaningful margin. day after day, month after month, year after year. That is the mechanism. That slow, quiet, chronic reduction is what produces visual blurring that no lens prescription ever fully resolves. That is what produces the sense that the world has been turned down a degree from what it was. Now I need to tell you something about where the compression tends to live, because most people who try to do something about their neck are addressing the wrong location. When people feel tension in the neck and decide to stretch it, they usually tilt the chin toward the chest or drag one ear toward the shoulder. The sensation they feel is in the middle portion of the cervical spine, around the 5th and 6th vertebrae. That region is already the most mobile segment of the entire cervical spine. Pushing additional movement into it is not therapeutic. In some cases, it creates new mechanical problems. The restrictions that actually affect vertebrobasilar circulation live in two specific zones. The first is the cervicothoracic junction, the transition between the base of the neck and the upper thoracic spine. This is the region where years of forward head posture accumulate into what is sometimes called a dowager's hump, that rounded prominence at the base of the neck. I want to be direct about this. That structure is not primarily cosmetic. It is a chronic, mechanical blockage. It represents accumulated joint stiffness and postural compensation that directly compromises the upward passage of the vertebral arteries through that region. The second critical zone is the upper cervical spine, specifically C1 and C2, the uppermost two vertebrae, where the vertebral arteries make their final wrap before entering the skull. This is where compression has the most direct and immediate impact on posterior brain perfusion. I need to pause here and address something that I find clinically significant because it comes up repeatedly. Patients who come to me with visual complaints almost universally have other symptoms that they have never connected to the vision problem. Symptoms they have been dismissing or attributing to stress or to getting older. And when I lay them all out together on the table, the picture becomes unmistakable. The first associated symptom is what my patients describe as a peculiar kind of fatigue that lives specifically behind the eyes. Not tired the way you feel after a long day. A pressure-adjacent heaviness that is there even after a full night's sleep. One woman described it to me as feeling like her eyes were doing twice the work for half the result. That sensation is not the eyes working too hard. That is the visual processing centers of the brain running on a reduced energy supply and struggling to perform a function that should be effortless. The second associated symptom is a brief visual disturbance when changing positions, particularly when rising from a seated position or turning the head quickly. A momentary wavering, a half-second where things smear slightly before settling. Most people attribute this to blood pressure changes or standing up too fast. In some cases, that attribution is correct. In many cases, it is not. What is actually happening is a transient further reduction in vertebrobasilar flow as the mechanical geometry of the spine shifts during movement, temporarily compressing the vertebral arteries further before they reopen. The third associated symptom is difficulty with visual complexity. Crowded scenes become harder to parse. A busy grocery store aisle, a dashboard full of instruments, a page dense with text. Processing multiple visual elements simultaneously requires the visual cortex to operate at or near full capacity. When that cortex is chronically underperfused, the first thing to go is not the basic ability to see. It is the ease of processing complex visual information. Things that used to feel effortless begin to require active concentration. Let me tell you about a patient I will call Catherine. She came to see me about 14 months ago. She was 68 years old, recently retired from a career as a librarian in a small city in the Pacific Northwest. She was precise, observant, the kind of person who noticed things carefully. She came to me because her visual acuity, despite 3 prescription updates in 4 years, continued to feel just slightly insufficient. Her ophthalmologist had ruled out glaucoma, macular degeneration, and significant cataract formation. Her retinas were in good shape for her age. She was, by every standard ocular measure, doing well. And yet she had stopped driving at night. She had started sitting closer to the television. She had quietly begun declining dinner invitations at restaurants she described as too dark. When I sat with Catherine and went through her complete history, what came out was this. For the past 2 years, she had been experiencing a dull tension that lived at the base of her skull almost every day, that she had attributed to tension headaches. She had been waking in the night 2 or 3 times a week with a brief sensation of visual disturbance before falling back to sleep, which she had attributed to the room being dark and her eyes adjusting. And she had noticed, though she had never mentioned it to any physician, that her reading comprehension had subtly declined. Not dramatically, she could still read. But she had started rereading paragraphs more often. Not because the words were unclear, but because the processing of them felt less automatic than it once had. She had not mentioned any of this to her eye doctor, because none of it seemed connected to the vision question. They were separate problems. The headaches were stress. The night waking was age. The comprehension was just getting older. They were not separate problems. They were one problem expressing itself through multiple channels. Chronic mechanical compression of the vertebral arteries in her upper cervical spine had been quietly reducing posterior brain perfusion for years. Her visual cortex was not damaged. It was not diseased. It was being slowly underfueled. We addressed the mechanical restriction systematically over 10 weeks, and we introduced the protocol I am going to walk you through today. At the 12-week mark, Catherine told me that the heaviness behind her eyes was gone. She had driven at night for the first time in 2 years. Her husband had commented without prompting that she seemed more present in conversation. The tension at the base of her skull had resolved almost entirely. She told me it felt like a layer of gauze had been removed from in front of everything. Not dramatic, not sudden. Just a steady, incremental return to what she now realized had been her baseline years earlier. That is, the restoration of posterior cerebral circulation, described by someone who experienced it firsthand. So let us talk about the protocol. We are going to work through 2 distinct blocks. Block 1 is focused on releasing the mechanical compression in the cervical spine and restoring the architecture that the vertebrobasilar circulation depends on. Block 2 is focused on directly rehabilitating the visual cortex and its coordination with the brain's spatial processing systems through targeted neurological challenge. For the first exercise in Block 1, I want you to locate your 7th cervical vertebra. Here is how. Let your chin drop gently toward your chest and run one finger slowly down the back of the neck toward its base. You will feel a bony prominence that protrudes more noticeably than its neighbors. That is C7, the vertebra prominens. Place the pad of your finger against the lateral surface of that spinous process. Begin rotating your head slowly to the right. As you rotate, apply a firm but gentle pressure with the finger in the same direction, assisting the vertebra through its range of motion. You will encounter a point of elastic resistance, the sensation of pressing against a taut band. That is the physiological end range of the joint capsule. That is your stopping point. Do not force through it. As you return your head to center, maintain the finger pressure for an additional 2 to 3 seconds before releasing. That sustained hold at end range is where the therapeutic benefit accumulates. The prolonged stretch of the joint capsule signals the surrounding musculature to release its protective contraction. Repeat on the left side. Then move your finger 1 vertebra lower and repeat the full sequence. The second exercise in Block 1 addresses the suboccipital muscle group. These are 4 small paired muscles that live in the space between the base of the skull and the top 2 cervical vertebrae. They are among the most densely innervated muscles in the body. In people with chronic forward head posture, which in my clinical experience now describes the majority of adults over 50, these muscles exist in a state of near constant contraction. They shorten, they stiffen, and because they sit directly adjacent to the path the vertebral arteries take before entering the skull, that chronic contraction generates sustained pressure on the final and most critical segment of the vertebrobasilar pathway. To release them, interlace your fingers behind your head just below the bony ridge at the base of the skull, the occipital ridge. Allow the weight of your hands to gently tip your chin toward your chest, while your fingers apply a mild upward traction at the base of the skull. What you are creating is a gentle separation between the atlas and the occiput, the uppermost joint in the entire spine. Hold this for 30 seconds, breathing slowly. You should feel a deep, diffuse release at the base of the skull. Not painful, not sharp. A warm, spreading ease. Repeat this 3 times. Follow with 2 minutes of slow, circular friction massage along both sides of the cervical spine, working from the base of the skull downward with firm, deliberate pressure from the fingertips. Third in Block 1 is a postural reset for the cervicothoracic junction, the base of the neck where so much of the chronic compression accumulates. Sit upright in a firm chair. Place a rolled towel or small firm cushion at the base of your neck at the level of that prominent 7th vertebra. Allow your head to rest back against it gently. Now draw your shoulder blades together and downward, as though trying to tuck them into your back pockets. Hold this retraction for 10 seconds, release, and repeat 8 times. What you are doing is actively reversing the forward rounding that years of desk work and screen time have built into that junction. Each repetition asks the chronically shortened anterior muscles to release and asks the chronically lengthened posterior muscles to reactivate. Consistent daily practice of this one movement alone produces measurable change in the posture of the cervicothoracic junction within 4 to 6 weeks. Now Block 2. The visual cortex is a trainable system. I cannot overstate how important this is because most people assume that visual decline associated with aging is simply a one-way road. It is not. The brain is neuroplastic. The visual cortex is among the most responsive regions in the brain to targeted, consistent challenge. The key is to challenge the system at or just beyond its current capacity, daily, in ways that are specific to the function you are trying to restore. The first exercise is what I call the near-far convergence drill. Sit in a well-lit room. Hold one finger at arm's length at eye level. Focus on your fingertip until it is completely sharp. Then, without pausing, shift your gaze to an object on the far wall, at least 15 feet away, and hold focus there until it is completely sharp. Then return to the fingertip. Each transition should take approximately 2 to 3 seconds of active focus finding before moving to the next shift. Do this for 2 minutes continuously. What this exercise trains is the accommodative and convergent systems of the visual cortex, the neural machinery responsible for rapidly adjusting focus across distances. In people with compromised posterior cerebral circulation, this system is often the first to show degradation. It requires significant metabolic energy to operate at full speed. Consistent daily drilling of this transition rebuilds the neural pathway efficiency around the mechanism, even when the mechanism itself is still being restored. The second exercise is peripheral visual tracking. Stand facing a wall at roughly arm's length. Without moving your eyes from a fixed central point on the wall, raise both hands to your sides at shoulder height. Begin slowly moving your right hand forward and backward in your peripheral field while holding your left hand still. Your task is to track the movement of your right hand using only peripheral vision while maintaining central gaze. After 30 seconds, switch. Move the left hand, still the right. Then begin moving both hands simultaneously in different patterns. What this challenges is the spatial processing and peripheral integration capacity of the visual cortex, the ability to maintain central clarity while simultaneously processing movement in the peripheral field. This is the capacity that erodes first in people who find busy visual environments increasingly effortful. It is also one of the most directly trainable. The third exercise is what I call the contrast sensitivity ladder. This requires nothing more than text of varying size and contrast. Print or display several lines of text beginning at normal reading size and decreasing through several steps to text that is, at your current visual capacity, at or just below the threshold of comfortable clarity. Read each line aloud at a deliberate pace. When you reach the line that requires noticeable effort, stay there for 30 seconds before moving to the next. Then return to the top and repeat. What this exercise does is drive consistent activation of the ventral visual stream, the processing pathway responsible for detail discrimination and contrast resolution. Driving it daily at the edge of its current capacity is one of the most effective ways to preserve and, in many cases, partially restore the resolution of central vision. Not because the lens is improving, because the neural processing of what the lens delivers is becoming more efficient. I want to say something before we close, and I want to say it plainly. The structure of medicine in this country is organized around the management of symptoms, not the resolution of underlying mechanisms. That is not an accusation. It is a description of how the system was built and what it rewards. An ophthalmologist who explains to a patient that their visual blurring may be caused by chronic compression of the vertebral arteries, reducing flow to the visual cortex, is not operating within the standard of care their training prepared them for. They are a specialist in the eye. They will address the eye. And they will do so competently and often helpfully. But the mechanism I have described to you today lives outside the boundaries of any single specialty. It falls between departments, and the patient, the person actually living in the body experiencing the symptoms, often falls into that same gap. That is why this channel exists, not to replace your physicians, not to discourage you from seeking evaluation, but to give you the anatomical framework your physicians may not have offered, so that when you walk into that appointment, you are asking better questions. You are asking about posterior cerebral perfusion. You are asking about vertebrobasilar circulation. You are asking whether the structure of your cervical spine has ever been assessed not for disc disease or nerve compression, but for its effect on blood flow. If your vision has been softening gradually, if the world has been losing 1 degree of its sharpness for longer than feels comfortable, the problem may not be your lenses. The most common mechanical cause of compromised posterior cerebral circulation is chronic cervical restriction, compressing the vertebral arteries at the upper cervical spine and the cervicothoracic junction. The solution is to release that restriction systematically and to train the visual cortex daily at the boundary of its current capacity. Do these exercises consistently, not occasionally, not when you remember. Every day. The system that processes your sight is trainable. The blood supply that fuels it is, in the majority of cases, restorable. But it requires consistent, targeted input. Give it that input. I want to hear from you. Leave your age in the comments below. I read every one of them. It tells me who this information is reaching, and it shapes the videos I build next. If what I described today reframed something you have been experiencing and could not explain, subscribe to this channel right now and hit the like button. We are building a community here. People who refuse to accept slow decline as the only available story. People who want to understand their own biology well enough to do something meaningful about it. Every person who subscribes brings this information closer to someone who needs it. I am Dr. Reed Cross. The visual system is more capable of restoration than most people have ever been told. Give it the right input. Be consistent. And I will see you in the next video.